can I have my slides up, please? Okay, right. So just again, on the same theme, treating perforation, we're used to coils, we're used to fat and thrombin, etc. But sometimes you have to act a little bit faster, or sometimes they're not available. So I'm just going to show you a case that we used a little different approach to treat it. This was a 70-year-old man with a previous bypass operation, history of hypertension, COPD, bronchiectasis. As you can see, multiple problems. He had recurrent chest pain, and he had a coronary angiogram by one of our colleagues in a referring hospital, which showed severe proximal circumflex with heavy calcium, and moderate, his LV was moderate with ejection fraction of 46%. Both the lima and the vein graft to the RCA were patent. So he was sent for PCI, accepted him for PCI and rotablation to the circumflex. This was his angiogram when he came for the procedure. You could see the severe stenosis and the calcium, eccentric calcium in the circumflex, as well as in the OM branch. So again, this was, I mentioned this a little bit earlier, cases like this, I often don't use 125 very often, but when it is severe stenosis or tortuous, this is probably where I could use the 125, prepare the lesion, then you could upgrade. Of course, that will have implication financially, but nonetheless, anyway, we did this with 125, then 175 because the artery is big. And this was after the second run of the BER 175. We swapped the wire at this stage. We have I think a cyan black, this was the wire that went into the circumflex, and we had to use a body wire to deliver the stent. So the proximal area was treated, stented, and both dilated, and you can see that it's quite very good result at the end. We still have the OM subtotally occluded, and that needed to be treated. However, I was going to leave it alone, and then we noticed this big kind of staining at the distal vessel. The patient at this stage was hemodynamically stable. Pressure is slightly kind of a little bit low. Echocardiogram, we did not see much. There was a very small rim of pericardial effusion. But of course, bypass operation can be very difficult to judge if there's any, lots of problem with the pericardium. Because you have pockets of pericardium, and you could have a localized, loculated pericardial effusion that could cause hemodynamic compromise despite not seeing much pericardial effusion. So at this stage, with the patient just kind of hemodynamically a little compromised, I thought we'll just monitor him for a little while, and if there's any change, we will have to treat this. And of course, treatment for this, it is a distal wire perforation. As I mentioned before, 90% of wire perforation are secondary to hydrophilic wire. And the demonstration by George, how when you're delivering anything, equipment with the resistance, the wire will move back and forth. And because it's hydrophilic, it could easily perforate the small vessel. And this is what happened in this case. So of course, we asked for the coil kit, and the coils were being used in the pediatric, and since that time, of course, we've changed. Now we have a coil kit in our lab, is separate from the pediatric. We used to have one kit for everything, because we don't use it very often. So now there's only one kit for the pericardial, for the cath lab adult one, rather than the shared with the pediatric one. So when we asked for this, I knew that this will require to be treated. And of course, coils are the main thing. The nurse went to get the coils from the pediatric part. But by that time, I thought it's much quicker. We have the 2O balloon that we used previously. So I ended up cutting the balloon in half. And we used the front bit of the balloon, put it on the wire. And we took a second balloon and delivered that small remnant of the balloon into, as you could see in here. So you could see 3 dots. The first one is half of the balloon cut, and that's the kind of intact balloon. You keep delivering it all the way down to here. And then we remove the wire, as you could see in here. So that balloon, half of the balloon stayed in the distal artery. Technically, all what you're trying to do is just to block that artery and cause the thrombosis. So whatever material you use, of course, compatible, would be acceptable. In this case, the balloon was a cheap, and that was on the table. We already opened it up. It's unfolded, so we cut it in half and used it that way. Of course, there is some caveat and there's some precaution in his. Don't think this is just as straightforward to do it, because, and I'll mention this in a second. So again, when we did this and removed it, we went back and did the OM and everything was okay, and the extravasation did not change. The patient was hemodynamically stable. There was no more issues with this. And this is exactly what happened in here. So you could see that half of the balloon that was used, we cut it. You put it on the wire, and you deliver it by a second balloon. You have to make sure you stop, obviously, before where the perforation is, like with any equipment that you're going to block the artery with, and you leave it there. So what are the precautions for this? And this is just a diagram of what you do. Cut in half, about 2-3 millimeters of the balloon, and you just use it, put it on the wire, and deliver it. Now, important to make sure that an unfolded balloon has gone through. Because if you put this remnant balloon and you get stuck in the middle, you cannot take it back. There's no way of retrieving it. Of course, you could use, you try to use a snare, or you try to use whatever way. However, you don't want to get to that stage. But this is because I've already put the unfolded balloon and dilated it, and this balloon has gone. I was comfortable that this small piece of the balloon is going to go forward. But it's really important to make sure this is the case before you deliver. You put this little piece of balloon on the wire and deliver it distally. Because again, if it doesn't get delivered and gets stuck somewhere, that's it. You cannot retrieve it. And it could become very difficult. And of course, you could block an artery where you did not want to block it. But that's how you could do it. You cut it, you pass it on the wire, and second balloon just to deliver it. And of course, you're going to stop before the perforation is, so it doesn't go out. And this will seal the artery, and this is what happened in this case. I have used it now twice. Not that I have too many perforation, but I did use it twice. When you're treating complex cases and difficult cases, really easy way to do it. And it's a very cheap way of doing it. We published it, and it had a good response because the balloon is on the table. It's cheap. You cut it, you use it, and it's really very helpful. Again, just to say, to emphasize the point that most wire perforations are self-contained, require no significant treatment. But it might be perceived as if the delivery of the balloon is uncontrolled. But if there's any resistance and inability to deliver it, then cannot be retrieved. Really, the important point in here, you make sure that there's an unfolded balloon that goes up and down before you put this remnant balloon so you don't lose it. And of course, we perceive that it can be advanced to distal and may exit through the perforation, but that's not the case because you know exactly what the perforation is and you'll be able to stop it. I mentioned a little earlier about, it's delivered after another balloon has passed. Just emphasizing the point because the message I want to get that if you are unable to deliver it, you cannot retrieve it. So make sure that there's a possibility of delivering it without any problem before you put it on. And the anatomy and the size of the perforation will be clear, so you're going to stop before that area of perforation and seal it. And with this, I say thank you.
Excellent. Thank you very much.